Good afternoon. I'm Cherie, the patient healthcare liaison for the Multiple Sclerosis Foundation. I am a certified MS nurse, and I myself have been living with MS. I've known for a little more than 30 years, but as I look back, it's been about 47 years since my first symptoms began. We do this Ask the MS Nurse webinar every couple of months so that you can ask questions that might pertain to symptom management or lifestyle changes, or even therapies that you might be considering or have heard about. So there are several ways that you can ask me questions today. If you are on Zoom, hover over the bottom of your screen and there is a Q&A box. You can type your questions into that, and it does allow you to type them anonymously if you don't want your first name used. Also, you can type them into the chat. If you're on Facebook and are watching this live on Facebook, type your questions or comments into the comments on the Facebook page, and Bhavya, who's sitting here behind screen with me, will translate those to me in the Zoom chat so I can pick up on them. Also, if you want to ask your question personally, there's a raise hand button. If you hover over the bottom center, actually to the right of center of the screen, you can click on the raise hand button and I'll see that and hopefully be able to recognize you, let you know that I'm ready to hear your question, and you can take yourself off mute and answer your question. If you are on a cell phone and want to ask the question, you have to hit *9 to unmute yourself and ask that question. So I'm ready to take questions. If any of you want to tick something into the chat box or to the Q&A, and we'll go ahead and start answering your questions. I have an anonymous attendee that is asked or says, I've had MS for 30 years and knee osteoarthritis. What is the best pain reliever? How often is too much for the body? With any of these pain relievers, you probably, the bottle will tell you not to take them for longer than a week to 10 days at a time, and it will tell you what the maximum daily dosage of that medication is. With osteoarthritis, I think I would ask your doctor, your primary doctor, your neurologist, if you're seeing an orthopedist, what they would recommend for pain relief. Generally, they don't recommend that you take something more than 2 or 3 times a day for longer than a week or so. A physical therapist could very well help you to manage that pain without actually taking pain relievers. And you might also find that something like, if there's a spot area of tenderness, and it's not just general tenderness, you might be able to get an over-the-counter lidocaine patch and put that over the area of pain. You'd leave that on for about 12 hours and then take it off for 12 hours. Okay, let's see. Do we have any more questions here? Linda says, I feel like I take so many medications daily. Baclofen, gabapentin, valsartan, levothyroxine, and many supplements, D, E, B, B1 and B12, magnesium. Is this bad for my liver? Most of the drugs that you're mentioning here, with the possible exception of gabapentin, are processed through the kidneys and not the liver. So I would say probably not. If you're taking a disease-modifying therapy, that might be processed by the liver. Several of the disease-modifying therapies may impact your liver enzymes. I'm wondering, vitamin E, we mentioned in the takeaways from the Consortium of multiple sclerosis centers last month, vitamin E can be carcinogenistic. So you probably want to eliminate the vitamin E. There's really no reason right now for anyone with MS to be taking vitamin E for their MS. B12 is urine excreted, as is B1. Vitamin D is really, it's stored in the fat cells, so it does not, it doesn't really impact the liver, although if you're toxic, it can screw up your liver enzymes. And we're now beginning to see liver toxicities in people that take more than 50,000 units per week. If you're taking a 50,000 unit dose, that should only be once a week maximum. And what we're seeing with toxicity for the vitamin D often looks like a flare. You're getting the symptoms that you would normally be getting during a flare. Whatever rears its head when you're getting a relapse or a flare with MS is likely to begin showing up if you're taking too much vitamin D. So magnesium is not bad for your liver either. An anonymous attendee says, is there anything that I can do about curled toes? Curled toes is generally related to spasticity. So it would be a matter of stretching your feet, of massaging them, of curling your toes upward instead of inward toward the sole of your foot. You want to curl them upward towards your ankle. Do that several times a day and hold that stretch for 20 to 30 seconds at a time. Let's see, we've got a couple from Facebook here. Arquieta says, hi, I've been diagnosed with MS in March. My doctor is considering me secondary progressive. What exactly is that? Secondary progressive MS is a form of MS that no longer is generally active. It can be active, but you're not having relapses as frequently as you would if you had relapsing remitting MS. People that have relapsing remitting MS and start out with relapsing remitting MS, if they're not taking a disease modifying therapy after an average of about 10 to 12 years, transition to secondary progressive. A disease modifying therapy doesn't cure that, but it does tend to tip it back into a much more stable form of MS if you're on a disease modifying therapy. Terry from Facebook asks, what is the best food or supplement for stiffness? There's not really a food or supplement specifically for stiffness. Stiffness is, another word for stiffness with MS is often spasticity. And so spasticity is ramped up, particularly when inflammation is present. And the food that causes the greatest inflammation in our body are sugar-based foods. Any sugared drink, sometimes you can be so sensitive to it that even the sugars in a tall glass of orange juice can trigger some of that stiffness and spasticity. So you want to do what you can to eliminate anything in your diet that has an added sugar in it, and that will help. But you also need to be stretching on a regular basis in order to help with that stiffness. Let's see. Okay, Linda is just responding that that she takes Ocrevus. So she had just asked a question about supplements and the medication she was attending or taking. Mimi says, mine is not so much pain, but more fatigue, especially with my left leg if I walk continuously for over 20 minutes. I'm taking delfampridine, but not sure if it's really working. Any other tips? Delphampridine only works for about 40% of people that take it. So if you don't think it's working for you, I think I would tend to go off of it for 2 or 3 weeks and see if the walking is worse and then go back onto it. Talk with your doctor, though, the person that prescribed it for you, to see if they agree with that. The other thing is, if with that particular drug, delphampridine is also known as Ampera. And so if you've started Ampera and you're taking it for walking speed or strength and you haven't noticed a real improvement by the time you've been on it for 3 weeks, you're one of that 60% for whom it does not work. So don't bother to refill it. We do expect that 60% of people that take this are not going to respond well to it. For those that don't respond well to Ampera or delphampridine, a supplement that seems to help some people with walking speed and strength is alpha lipoic acid, and that's available over the counter. You don't want to take mega doses, just the standard dose that's recommended on the bottle. An anonymous attendee says, pain under my big toe from bunion, possibly due to abnormal MS gait. Anything besides pain reliever for pain? I think if it's possibly due to a bunion, if you've had a bunion present, a podiatry referral is in order, and they can work with you on the foot pain. Okay, Katie says, is there anything to stop the soles of my feet feeling like they're on fire when I walk in shoes, but not with bare feet? Also, my toes go numb. Katie, has your doctor offered you something like gabapentin for the burning in your feet? That is a very common drug, so you might bring that question to your doctor. There's nothing that I know of that's shy of a prescription medication for that. So I would have that conversation with your doctor.
So this is an anonymous attendee, and they say, I hear a lot of people say they take magnesium at night to help with sleep and other things too. Googling magnesium, there are so many different kinds. Which one would be best, and how much should I take per day? Thank you.
I think it's the magnesium gluconate or carbonate that is most frequently used. And I wouldn't take a large dose. I would take the smallest dose possible. And that can help both with, sleep and also with any spasms or cramping that you might have in your legs or feet that might be interrupting your sleep.
Okay, great. We also have from Vishira, been having dizziness and vertigo. Any suggestions on what to take to combat that dizzy feeling?
There's really not a lot to combat dizziness. Dizziness is a symptom that should be brought up with your doctor, and instead of trying to self-treat, because there are any number of things that could be causing the dizziness. It could be caused by an infection. It could be caused by ear crystals in your inner ear that need to be repositioned, and there are physical therapists that can work with you on that. It could be caused by a neurological problem. Oftentimes dizziness is treated with drugs that are in the antihistamine class. So I would not suggest anything for you to take for dizziness, but I do want you checking with your doctor on that.
Thank you. And Linda has a few things that she wants to mention, but she said, what are your thoughts on Mavenclad for older patients? She's heard it's like an exit plan treatment, because after a few years of hope, or after a few years, you hope to be finished with DMT. There is a trial going on for older patients, if stable, to go off DMTs. She'd like your thoughts on that.
I don't agree with that at all. That came out of the rising costs of disease-modifying therapies, and people thought, well, the immune system normally slows down after a person gets to 55 or 60. So it makes sense that MS slows down. And if you've got people that aren't on an MS therapy, Typically, they transition into secondary progressive MS after about the age of 55 or 60 anyway. Well, secondary progressive MS is worse than relapsing remitting MS as far as disability in an individual. So we don't want you to get to secondary progressive. We want you to be treated. We want you to stay on medication as long as you're tolerating it and it's financially feasible for you to do so. I'm over 70 and I'm still on my disease modifying therapy. And I have no intention, nor does my doctor, of ever taking me off of it as long as I'm tolerating it and it's not contraindicated. Because the times that I've tried to come off of it over the age of 62, 65, I relapsed again. So I'm not willing to take that risk. As far as Mavenclad is concerned, Mavenclad traditionally has shown very good efficacy. You take it, I think you take 10 doses the first year and another 10 the second year. It's an oral medication. And after that, most people never need anything. I think Dr. Mark Friedman in Canada coined the term exit strategy for that drug because he thought that it might be a less costly, less invasive way to get off of medication because it does sort of reset the immune system.
Okay, she also said that she's been on Avonex 25 years. How do I know when it's time to switch?
I would say if you've been on Avonex for 25 years and you've not had any MRI changes in the last 5 years and no new symptoms of a relapse or new MS symptoms, Avonex was one of the drugs tested in that trial taking people off of drugs. I will say that there were a couple of different trials that looked at this, and the people that came off their drug, 32% of those individuals had new disease activity. 33% of those who were on those drugs had new disease activity during that time. So statistically, they weren't significant. The only drugs that were looked at in this trial that was taking people off of medications were drugs like Avonex, Rebif, Betaseron, or their generics, and also Copaxone or glutathione acetate and their generics. They did not look at any of the drugs that have been put out since about 2007. So it was all the older drugs. So if you've been on Avonex for 25 years, you are one of those people if you've not had any new disease activity that might do well coming off of your medication. All right, I see something now. Archaeata, I think it's Archaeata. I'm on Zeposia. They found a lesion behind my left eye. I also have the same issue with my legs. What was the over-the-counter that you mentioned? The over-the-counter, you mean for alpha lipoic acid for walking? That's not the same thing as Zeposia, and it has no impact on lesion load at all. All right, let me see. I now see that the Q&A is coming up, so I may be able to. Oxybutynin or Gentessa better for bladder symptoms? I've heard about both. I think it's a trial and error. So whatever your doctor is recommending. And another anonymous attendee asks, what DMT are you on? And the DMT that I've been on now since early 2014 is Rituxan. And I did have quite a relapse when I came off of it in 2017. I'd been stable and came off, and I had quite a relapse afterwards. So that's why my doctor has said that we're not going to stop it. Rituxan is in the same category of drug as Ocrevus and Briumvi and Truxima. It's a B cell depleter, or also known as an anti-CD20 drug. And as I mentioned last month, in the takeaways from the Consortium of Multiple Sclerosis Centers, This is the most effective class of drug that we currently have on the market. Hopefully, the BTK inhibitors that are coming down the pike, which will be an oral medication, will be as effective. It seems to look like that. And Teresa says, at 70, what are your symptoms? I agree. I'm not going to stop my DMT. Thanks for the reinforcement. I have many of the same symptoms I've always had. It's just that I've gotten very used to having them in the background. When I get overheated or overtired, they resume. And it's mostly visual symptoms in my left eye. I have to occasionally catheterize because I can't empty my bladder. The majority of my symptoms are related to gait. I have a bit of a foot drop. I hike my hips some, so that often means that I have to deal with hip pain or sleep interruptions. So it's the same symptoms that I had for years when I was younger. It's just that they're a little milder now that I'm on this medication. An anonymous attendee says, I'm currently on casimta, which is a self-injection once a month. I'm doing okay with no side effects, and my recent brain MRI shows no change from a year ago. I've been reading about Mavenclad, though, and only having to take pills for 2 years for 2 weeks each year is super appealing. It would be stupid to ask my doc to take me. Would it be stupid to ask my doc to take me off casimta and put me on Mavenclad? I would say that it's a reasonable conversation to have and just listen to what they're thinking. I think casimta is probably a little bit more effective than Mavenclad is. So if you're able to afford the co-pays on casimta and you're tolerating it well, it's a little bit more effective than the Mavenclad is. Let's see. All right, I answered Arquetta. Linda, is Rituxan now FDA approved for MS? No, but it is used across the United States, across the world, probably more than Ocrevus is, and just as effectively. And it's cheaper. Arquetta says, can you spell that medication? I think you're asking about alpha lipoic acid. That's ALPHALIPOIC acid. Bhavya says, Lynn from Facebook asks, I've been on Copaxone since 2009 and don't want to go off, but my neuro is suggesting it. Why? My guess is that, Lynn, you are over the age of 55. People that have been on Copaxone or the interferons, the injectable interferons, for longer than 10 or 15 years and are over the age of 55, if they've got no new disease activity, no relapses, no changes on the MRI, it seems that there's a good chance that you can safely go off of it. If you don't want to go off of it and you're not comfortable going off of it, you probably are going to be able to stay on it. Just have that conversation with your doctor. And if your doctor's not willing to do that, then you may need to find a new doctor. As both Dr. Boster and Dr. Thrower have said repeatedly in their webinars, there is no right age to stop a disease-modifying therapy. Neither one of them recommends going off your disease-modifying therapy unless there are problems with it. Let's see, Rituxan, Rituxan, that's also called rituximab, Rituximab. Whenever you see an MAB at the end of a drug name, that's monoclonal antibody. And so it attaches itself to the antibodies that your body is producing that causes the central nervous system damage to happen. And it kind of lets them fall out and not attack your system.
Cherie, excuse me, I don't know if your system is allowing you to see the older Q&As. So I'm going to read it to you. Do you see the one that says I had a relapse in June? I had 3 days.
Oh, wait a minute. That I see Lillian's about being on Aubagio.
Nope,
That just
nope.
popped in. Okay, we'll get to Lillian in a minute. So you read the older one. Go ahead.
This is an anonymous attendee who's saying he had a relapse in June, and had I guess in June they had a relapse that for 3 days of IV steroids, and recently received their first dose of Tysabri last week, and I'm still feeling I'm in a relapse. When should I start feeling better? I was on Rituxan 21/2 years. I don't know what that means. Last infusion of it was in March. Oh, 2.5, forgive me, 2.5 years. The last infusion was in March.
I found with me when I've had relapses, my relapses did not go away with steroids. The first couple of rounds of steroids that I had seemed to take the edge off the relapse. It never took the relapse. Oh, I've just lost my video again.
It's a cute picture of you.
Can you hear me still?
Yes, we can hear you perfectly.
Afraid that I'm going to lose Zoom again. And if that's the case, folks, I have to apologize for this. I sincerely hope that this lets up for you soon, but it's not likely to let up for it. The edge will come off of it. These drugs are not, Tysabri does not take the relapse away. Tysabri keeps more damage from happening. So this is something that will ease over time. Okay. Lillian says, I've been on Aubagio and haven't taken it in the past 3 years, and now I'm in a nursing home facility and do believe it's because of a severe relapse. Can you tell me, if you can tell me anything about Aubagio and returning back to it, I would greatly appreciate it. There's nothing wrong with going back on it. If you've had a relapse or new disease activity, just ask your doctor to put you back on.
Okay, and we do have an anonymous one from before that said, can you tell her what the best size of wheels for a walker or a rollator is on walker 4 wheels, and are 2 wheels better?
That's a question not for me, but for a physical therapist.
Okay.
They're the experts in the right walker, the right assistive device to have to aid in walking. And it's individual. It's not an across the board answer for everyone. It depends a lot on your height and on your weight and on how much walking you're doing. So that's a question that's going to have to be answered by a physical therapist. Are there any older ones still there?
We do have an anonymous attendee who's asking if you personally have relapsing or secondary progressive MS.
My doctor has never told me one way or the other. My sense is that I have a secondary progressive at this point, and I think I tipped into that when I had COVID before Christmas last December. I had a bunch of symptoms that ramped up with the COVID and have not completely let go. And I honestly believe that I'm fitting that criteria of secondary progressive at this point.
Okay, so Arkita asked a couple questions. One of them way back was, and I don't know that you answered this or not, I am on Zeposia. They found a lesion behind my left eye.
I did answer that.
Okay,
yeah.
So now she's asking, is the medication that you personally are on what you prefer, or do you think it all depends, because she's still trying to figure this whole thing out? She doesn't know what to expect.
You know, I honestly went on Rituxan because I could not afford the copays of Rebif that I had been on for several years and was doing well on when I transitioned to Medicare. And the copay when I transitioned to Medicare on Medicare Part D was $2,200 a month, and the insurance companies or the pharmaceutical companies cannot help with copays in persons that are on Medicare. There are foundations out there that can help with the copays. You have to be making a certain amount of money or less in order to get that copay assistance. But, you know, I did not feel when I first went on Rituxan that it was doing the job that my Rebif was doing. I felt like I had symptoms that had resurfaced and they weren't ramping back down. But after a couple of years on the Rituxan, I realized that it was probably the easiest medication I had ever taken. There were just no side effects from it at all. Other than that first infusion, I had some itching that they had to slow it down with. So at the moment, I prefer the Rituxan because it has treated me so well while I've been on it. An anonymous attendee is asking, can a person go off glutathione or acetate cold turkey? Yes.
Okay.
Linda says, I am 62 and trying to figure out what to take once I reach 65. How much is Rituxan? Rituxan is fully covered by Medicare. So once you reach 65, if you're living within the United States, Medicare covers everything that's done in an infusion center. So you should be able to get that at no cost to you. It is about half the cost per dose of what Ocrevus is, however. Okay. And questions are popping out of the chat. I don't know if Bobby is taking them out. Brenda says, I've been on Ocrevus for 2.5 years and tolerate infusions, including the steroid pre-med, extremely well. Is there any reason I should consider having no steroid with my Ocrevus? I occasionally hear of patients discontinuing or weaning off steroids. There are a couple reasons why you might want to have the discussion with your doctor about eliminating the steroid pre-med. And one of them is that you're female. I can see genetically from your name, you probably, women who are receiving steroids are far more likely to develop osteoporosis and fractures that are steroid induced. So that's something to consider. It's a relatively small dose of steroid and you're only getting it twice a year, but cumulatively your exposure to steroid is going to make you more susceptible to fractures. So yes, what they're doing often is giving you a couple of Tylenol and a Benadryl as a pre-med. And other than that first infusion that I had with Rituxan, I've had no need even for those, but my doctor says that he would rather I just stay on them. And Linda's asking if Ocrevus is covered by Medicare. And with most Medicare plans, yes, it is. You may have to pay a 20% copay, which is why I would recommend getting a supplemental policy, which picks up that 20%. An anonymous attendee is asking, what side effects does Rituxan have? Probably nothing that you would feel that would impact your quality of life. The real concern with this class of drugs, again, that class of drugs includes Rituxan, Ocrevus, Briumvi, Truxima, Casimta, is that it lowers your lymphocyte count, and lymphocytes help us to fight infection and it helps us to build immunity. So if you're on this class of drug, you may not be able to ward off viruses or bacterial infections. People on this class of drug have a slightly higher incidence of urinary tract infections and respiratory tract infections. And we may not be able to develop antibodies to different vaccines, including the COVID vaccine. But other than that, there really aren't any side effects that are uncomfortable with Rituxan. Debbie says, I was diagnosed in 2016 at age 59 with relapsing remitting MS and put on Tecfidera. Early in the COVID pandemic was switched to glutopa, and that is the generic of Copaxone for those that are unfamiliar with that. I'm still on glutopa with no relapses or changes in my MRI. I'm still on glutopa and will be turning 66 this year. The doctor wants to stop disease-modifying therapies due to my age. You've only been diagnosed for about 10 years. And again, this is a decision that you have to have with your doctor. If you're taking the 20 milligrams daily, then it may be at a point where taking a daily injection is problematic for you, or your skin is needing a break. It certainly wouldn't hurt to go off of it on a trial basis and just be followed a little more closely. Usually when we're taking someone off of a disease-modifying therapy because of their age, we see them in the office every 3 or 4 months instead of every 6 months to a year for the first 1.5 to 2 years. We might also get an MRI every 6 months just to see if there's any disease activity happening. And let's see, Debbie is asking, is Aubagio a good alternative to glutopa? Oh, you're putting it in both again, Debbie. Please do not put both chat and question and answer. It kind of gums up the works. Is Aubagio a good alternative for my age? It may be. That's a good discussion to have with your doctor. It's one of the lower efficacy medications, but if you have a milder form of MS or a less active form, it may be exactly all you need. Lynn from Facebook is asking, what do you suggest for severe leg pain? I broke both feet right before I was diagnosed with MS, so my feet always hurt, but these leg pains are at a new level for me. You know, Lynn, I don't know. I don't know your history. I don't know what your x-rays are looking like. I don't know what your MRI says. I don't know what medications you're on. So I really can't answer that question. If you're diabetic, severe leg and foot pain may be part of the diabetic profile. So I would be sure to sit down with your primary care, let them know what is going on, and see if they can't give you an idea of how to manage that pain. And I'm so sorry that this has been interrupted. I may have to order a new camera. This is a new camera that I've got here because the camera on my computer stopped working, and this has worked for about 6 months. An anonymous attendee is asking, are there any foods that produce inflammation in MS? There certainly are. Anything that has processed sugar in it. Anything with white sugar, even brown sugar, any dessert that is not fruit. So oftentimes glutens can be inflammation producing if you're sensitive to glutens. If you're sensitive to dairy, dairy products can produce inflammation. You want to get as much processed food out of your diet as possible. So no pre-prepared meals that have any additives in them. Nothing that comes off the shelf with an ingredients list that you can't pronounce. Those are all processed foods, flavor enhancers, preservatives, dyes, anything like that can cause inflammation. Do we have any more? All right, Katie says, is it a nerve problem in my feet connected to the burning soles? As I've been told, it's an edema as they swell with a dent in the top part of my foot. I'm having another nerve conduction study next week. Many people with MS have swollen feet and legs, and it's often a result of sitting for longer periods of time than we're walking. I find with myself, however, that the more I walk, particularly in hot weather, the more my feet swell. And that could be related to problems with the autonomic nervous system instead of the central nervous system. It may be unrelated to the MS. So your primary care is a good person to help you figure out what's going on and why. And if there's something like maybe a diuretic, a water pill that you can take occasionally, then they may recommend that. Bashira says, in your last webinar, you mentioned from your conference notes that MS impacts African Americans much more progressively. Any idea why? There are theories on that, and part of it is that oftentimes people of African American heritage may live in areas that are underserved with MS neurologists. There is still, and this was brought up again at the consortium, there is still a bias within the medical school curricula that there are differences in African Americans over Caucasians. People believe that there's a lower there's a higher threshold for pain in people of African descent. They believe that they don't respond as severely as Caucasians do to pain. So it's just a horrible, horrible bias. And I think as a result of that, sometimes that translates into a lower level of care. And that may be one of the reasons why we now know that at least 90% of African Americans do not have any response to interferons or glutarin or acetate to treat their MS, but they were not included in any of the clinical trials, so we had no way of knowing that. So, an anonymous attendee asks, is there a new dye out for MRIs, or is it still being studied? I am allergic to the gadolinium dye. I believe that they have an alternate to gadolinium now that people that are allergic to gadolinium may safely take. So you can certainly ask that and see if there's not something you can take as an alternative. Another anonymous attendee says, can the brain atrophy seen in MS make one more susceptible to dementia later in life? It is thought that, yes, that is the case. One of the things that Dr. Boster mentioned in his Ask the MS Expert last evening was that we now have seen for the years of usage that we've had with our B-cell depletion medications, the anti-CD20 meds such as Ocrevus, Rituxan, Truxima, Briumvi, Casimta, that they seem to protect against brain volume loss, whereas the other drugs have not shown that to be the case. So we're seeing less brain atrophy when people are on this class of drugs. Archietta says, I have headaches every day, mostly on the left side. I believe it may be where I learned I have the largest lesion on my brain. What can I take? If you're having one-sided headaches daily, it may well be a migraine syndrome. We do not have pain where the lesions are located. We simply do not. There are no nerve endings in the brain for pain. So that is, I know it makes sense if you didn't know that to think that that's where the pain is originating from. It's not originating from the lesions. I suspect it's a migraine or even a tension type of thing if it's one side. If you're sitting on the telephone with your head tipped to the side, you may well be getting a stiff neck, and that could be causing a one-sided headache on a regular basis. If you're sitting at the computer all day or tipping your head down into your cell phone or tablet, those things can also cause tension in the neck and a headache on a regular basis. Linda wants to know, how often should an MRI be taken if you're stable? Dr. Boster was asked that question last night, and what he said is that if you can afford it, if your insurance will pay for it, I want to see an MRI every year regardless. If you're stable, it doesn't matter. I still want to see it every year. If you can't do it every year, then I want to see it every other year. I personally, that's his personal response to that question. I have not had an MRI it's going on 4 years now. Actually, I did have one 2 years ago, but it wasn't for the MS. So I think it's entirely up to your MS neurologist as to what they want. And does Medicare cover mobility aids at all from an anonymous attendee? Yes, they do. If it's a prescribed mobility aid, not if you go to CVS and pick up a cane. No, they will not cover that. If you have a prescription for a mobility aid, Medicare covers it. Part B, Medicare covers 80% of the cost of it. If you have a supplemental plan and it's prescribed, they pick up the other 20%. Will Medicare MRIs be covered 100%? Generally, yes. Again, you may have to have that supplemental policy to help cover the cost. And most supplemental policies are going to cost you under $100 a month, but that's certainly worth it if it's picking up any remaining copays. Okay. Is turmeric a supplement to take? Turmeric is thought to be anti-inflammatory. I really don't think that there's an over-the-counter turmeric out there available that has enough anti-inflammatory properties to impact the central nervous system inflammation. So it may impact inflammation if, for example, if you've got asthma or you're recovering from a cold or the flu, something like that. But I don't think it's really impactful on somebody with MS for central nervous system. And both our Q&A and our chat are currently empty. Deb, can you see if anybody's got a hand raised?
I see a question that's still here from a Facebook participant, and I believe you already answered it, but I just want to make sure that you can see it and that it has been answered. It was from Lynn from Facebook about the fact that she had broken both her feet.
Yeah, I got that. I answered that.
Okay,
That's probably not related to MS. That's probably related to an injury, and it could be even related to an early diabetes.
okay.
So she
And
needs to talk to her primary about that.
Okay, let's just make sure nobody is waiting to actually talk to you live. And no, they're not. So, no.
And again, folks, I apologize for the disruption of the webinar with technical difficulties.
Well, it happens. And that's why I love Zoom, because it doesn't matter what happens. It's still wonderful.
Okay, an anonymous attendee is asking, is a nutritionist or a dietitian the best? I err on the side of the dietitian. The dietitian can't be a dietitian without real training. A nutritionist can be a self-proclaimed nutritionist. And nutritionists, people who advertise themselves as nutritionists, oftentimes have, on a pyramid sales scheme, supplements that they can give you that they make most of their money on. And they tend to be very expensive. And for people that have MS, I don't want you taking any of those supplements because they can boost your immune system and make your MS worse.
Okay. I do have a hand up. Let's see. I don't know if that's my hand.
Your hand is up.
Yeah. No.
I can see that.
Okay. Good. I don't see any more questions. Unless someone has one, we're almost at the time.
And Mimi says, thank you.
Mm-hmm.
I'll let you then do an outtake and
Okay.
oh, best diet for MS attendee. An anonymous attendee asks, there is no best diet for MS. All of the diets that are touted to help MS have several things in common. They have no preservatives, flavor enhancers, additives, or added sugars. They are all made from whole foods and not pre-processed foods. Doesn't matter what they are. So you pick a diet that you like. If you're vegan, go vegan, but not packaged vegan meals, not the Beyond Meats, because they are so full of additives and flavor enhancers that they can really, really mess with your MS.
Good point. I eat a lot of that. I'm going to have to look, and I
Yeah,
don't have
anybody that is eating the Beyond products because they're vegan or vegetarian, read the ingredient list. They're not all natural products. There are flavor enhancers in there to make them taste like meat, even though they're not. They don't have animal products in them, but they are so awful for your MS or for any autoimmune disease. It's not funny.
Okay.
And there's a couple of people in both the chat and the Q&A who are saying thank you, that you've learned a lot. And I just really appreciate everybody's patience with these difficulties. I'm so sorry.
Oh, Cherie, you're wonderful, and all your information. You're so warm and just so genuine when you're answering questions. We love having you. I am going to go ahead and say our little outro, to say goodbye to everyone. So that does bring us to the end of our time. Thank you for all your questions. And if you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook page and YouTube channels. Reply to your registration email for information on how to access the recordings or to sign up for our newsletter to learn about upcoming events. Our next teleconference is going to be this coming Monday, July 24th at 4:00 p.m. Eastern. And our speaker is going to be Herb Karpatkin. Dr. Herb is an MS certified physical therapist, and he is going to do every other month. We're asked, just like we did ask the MS nurse, this is going to be asked the physical therapist. And he's really wonderful at answering your questions about PT. So that's going to be this coming Monday. We're so lucky to have Cherie here. And, Cherie, I keep saying it over and over again, but you are such an asset to the Multiple Sclerosis Foundation and everything that you do for us, whether it's writing, whether it's answering questions, all of that stuff. We're just thrilled to have you. As you leave the conference today, a survey is going to appear on your screen. Please take the opportunity to fill that out, because it not only tells us what you're looking for future topics, but also the ones that are most meaningful to you. And that's really what we want to provide, right? The best information, the best programs, and things that are meaningful. Because if it's not meaningful, you're not going to come and you're not going to learn. So our sincere thanks to all of our attendees for your participation, and especially to Cherie. So who really is, I refer to these people that do this with the Q&A for 1 hour, Energizer bunnies. And you don't even bring water to drink in between each question. So you're wonderful. And please don't beat yourself up, because the technical stuff is just part of being in this world, right? We have technical difficulties. But thank you for answering all the questions. So have a wonderful evening, everybody. Thank you again for coming. And she will be back, not this coming month, but the next one, doing the exact same thing. And if you go to our website, you'll be able to see exactly what dates that will be, or just check your Facebook page, because we also put the graphic and the invitation on that. So thank you, everyone. Have a wonderful evening, and we'll see you again soon.